Hello, I'm Tony Gershik from the University Hospitals of Leicester. It's my pleasure to welcome you here today at EuroPCR, where we'll be discussing the so-called appropriateness or inappropriateness of stenting and coronary intervention. Now, it might seem very odd to you that anyone should receive an inappropriate stent, but that certainly has been the real storm that has hit the United States over the last 2 years. It's hardly for us to judge why any stent may be inappropriately deployed, but there clearly are issues that are blurred when there are some patients where the indications may not be so clear. So here today I'm joined by three experts and opinionated experts who are going to tell us their views on the issues related to the storm that occurred in the United States about inappropriateness of stenting. Mostly what this has done is helped us to reflect on our own views, here in Europe about whether or not we truly know whether there's any inappropriate stenting going on, and how we sort of manage patients with coronary artery disease, particularly stable coronary artery disease, in the light of the COURAGE data. So without further ado, I'm going to introduce my panelists. Firstly, on my right is Antonio Colombo from Columbus University Milan. Welcome. Then I have Rob Byrne from the German Heart Center. Welcome.
Thanks.
And of course, Sunil Rao, well known from the Duke University, North Carolina. So without further ado, I think what I'll do is I'll turn to you, Sunil, first of all, because you're the honorary American here, who's going to give us your perspective on the whole issue of whether or not there was inappropriate stenting, being careful, of course, to not make any prejudgments, to talk in general terms about appropriateness of stenting as it hit the United States.
Sure. So I think it's important to provide some background with respect to what the appropriate use criteria are. They were really born out of two simultaneous influences. The first, of course, is the professional society, the American College of Cardiology, wanting to make sure that patients receive the right therapies. But the second, and probably more influential now, is the fact that there's been tremendous changes in the way healthcare is delivered in the United States, with so much more attention being paid to saving money. And so the idea behind the appropriate use guidelines was to get together a group of experts to go through different clinical scenarios and develop whether or not PCI in a specific clinical situation, albeit contrived, these are not real cases, would be appropriate, inappropriate, or uncertain. So there are certain instances in which PCI was considered to be very appropriate, so a patient who had failed medical therapy, for example. Now, what's interesting about the appropriate use criteria is that, like all things that the professional societies put out, it's meant to be a guideline. It's meant to allow physicians and operators to think about what they're doing before they do it. The challenge, of course, is that patients don't always fit into very neat scenarios. And one of the challenges that I think the U.S. is facing, and I would guess that Europe is facing as well, is that trying to enforce these appropriate use guidelines, if that's the correct term, is challenging because our registry data is not set up to capture information that's granular enough to get at whether something is appropriate or not.
Okay, so we'll come back to people's opinions of what's appropriate, what's not appropriate, but just succinctly give me your views on how this storm has actually played out in the United States. How has it changed clinical practice? In the background of the COURAGE data as well, perhaps, but particularly
Sure.
in relationship to so-called inappropriate stenting.
Yeah, I think the biggest thing that's influenced people's practice is really high-profile cases that have gotten a lot of national media attention about well-known cardiologists being brought to litigation by their hospitals for putting in inappropriate stents. That has caused all of us to pause, and in an environment like we practice in the United States, we're very worried about malpractice litigation.
Okay.
So if there's one positive outcome, it has caused us to at least pause and think a little bit. The negative outcome, of course, is that we're all practicing defensive medicine, which is not good.
Okay. Well, as I said, I think it's made us reflect on our own practice in Europe, whether or not there's so-called inappropriate stenting. I think inappropriate here in Europe perhaps means more about how you manage patients medically. So Antonio, very experienced chap, tell us about, do you think there's so-called inappropriate stenting, over-stenting in Europe, and tell us how you would manage your patients who have perhaps come to you with a bit of angina.
Yeah, I think it's a very important topic that we are discussing. Before going into what I believe is appropriate or inappropriate, I think we have to consider a basic difference between medicine in Europe versus United States. the compensation in most institutions in the United States is given by the number of procedures performed, while in Europe, with some exceptions, most of the hospitals work in the socialized environment where you work from 9 to 5, let's say, and doesn't really matter how many procedures you do within a certain limit, of course. So I think there is a more basic incentive to perform procedure in one environment versus the other. Of course, we are all physicians and we understand that incentive is not our mission, but this is an important difference. Having this in mind, I go back to the word appropriate. We know how something that is inappropriate today will become appropriate 2 years from now, or vice versa. So I think we have to be a little bit open scientifically and ethically to define something inappropriate, because you know how much science changes and makes us gastrectomy was totally appropriate to treat ulcer 10 years ago, and now it's grossly inappropriate.
So let me stop you there. Let me just focus and just ask you, we're changing this now from inappropriate to perhaps not necessarily needed stenting. Is that where we're moving in Europe?
Yes, but I think there are two situations where we have that we need to consider. One is to place a stent in a lesion which looks angiographically critical or may not look critical. And one is to place a stent in a lesion which is angiographically critical but is not producing symptoms to the patient or giving to the patient sufficiently ischemia according to the current standards. I believe the two situations are different. I would say that the first situation is really, at least for the current knowledge, inappropriate, because the lesion, which is 20-30%, it's a real forward thinking to imagine that that lesion needs a stent.
On that lesion? Do you do FFR and on these so-called lesions that may not be obvious for stenting?
I think you should do FFR at least if they are not obvious for stenting. I believe the concept of plaque sealing, it's a little bit waiting for to be proven.
So let's leave it that you think that patients who may have intermediate lesions and have probably quite well controlled symptoms should be perhaps not necessarily stented. Is that what you're saying?
I would say that this is an area open to debate.
Okay, so let me turn to Rob. Rob, the courage data acolytes would say that you really should try very hard to make sure your patient's symptomatic on really maximal medical therapy.
Yeah. Yeah.
So, you know, we have moderately strong views, perhaps as strong views perhaps as some of the courage investigators about this. What are your views about whether or not patients should be tolerating medication, whether or not they're truly asymptomatic? How do you manage such patients?
Yeah. I think it's important, perhaps from the outset, to clarify the extent of the problem and to clarify the patient population that we're dealing with. Because we all know from our practice that perhaps 60 to 70% of patients are going to be, who come to our cath lab for PCI, are going to be patients with acute coronary syndrome, unstable angina, and perhaps ST elevation myocardial infarction. So this part of our practice is not open for discussion in the current debate.
But I'm going to stop, because unnecessary is unnecessary for one patient. So it's slightly irrelevant with how big the population is. So I agree that it's not 60%, it's 40, 45% most practices. Yeah. But so how do you manage such patients? Are you influenced by courage data? Do you try very hard to get your patients asymptomatic with lots of medication, appropriate optimal medication?
Yeah, I think courage was an interesting study, and certainly it's influenced all of our practices to one extent or another, perhaps arguably greater on the other side of the Atlantic than here in Europe. it was a trial which showed failed to detect a significant difference in terms of symptom relief between PCI and optimal medical therapy. But I think we need to take into account that optimal PCI was perhaps not performed. Certainly these patients got optimal medical therapy. Whether we can realise these targets in routine clinical practice in terms of sticking to the medications that are prescribed or not is open to question.
It's very hard, isn't it, for some patients to tolerate all this medication. Before I go to Sunil and ask him a little bit about whether courage has changed practice in the United States, Antonio's two cases, you've got a patient who's perhaps got some symptoms, got a lesion, maybe have an FFR of 0.8 or so.
Yeah.
Would you try to treat that patient medically first of all? Do you have any information on whether it's better or prognostically or symptomatically to treat that patient with a stent if they've got a flow limiting lesion, say 0.78, 0.79?
I mean, it's difficult to know. You're dealing there with the grey area of an FFR between, for example, 0.75 and 0.80. I suppose to a large extent it comes down to clinical judgment and perhaps also to patient preference and to resource availability. In countries with greater resource availability, I don't think it's a coincidence, but you do see higher rates of PCI per million population in those countries that spend large proportions of their GDP on healthcare, such as the United States, such as Germany, where you're well in excess of 10%.
What about Antonio's other patient, which I think was a patient with an obtuse marginal tight stenosis who's pretty asymptomatic? What would you do there? Because remember, Courage said you're allowed to do an angiogram. So here you are, you've got this patient who's relatively asymptomatic, very tight lesion, a biggish OM, not necessarily a prognostic lesion.
Yeah.
What do you do with that patient?
I think in that patient, if the patient is truly asymptomatic, and that's something perhaps
There's a truly asymptomatic, slightly different. Here's a patient who's on 3 bits of medication, gets mild angina on maximal exertion.
Yeah. I mean, I think we possibly have to be guided by ischemic territory involved in a situation like that, and certainly in our centre our modality of choice tends to be nuclear imaging. I know that varies from practice to practice, and people are looking for an ischemic territory maybe greater than 10% as a guideline to intervene.
Based on almost no data at all, except for the Courage nuclear. I'll come to you in a second, but you brought up this patient, Antonio. What are you going to do with this patient? Is it inappropriate to stent this patient?
Let's be practical. You have this patient with a 90% stenosis on the obtuse margin. He's taking 3 medications plus aspirin, and you tell you can continue to take these 3 medications, or we can place a stent. You can only have to take 2 medications, aspirin and Plavix. And the patient ask you why you don't place a stent, you don't get rid of this narrowing. What makes you reluctant? There is a courage, there is no major advantage, you're not going to live longer if we do that. But doctor, instead of taking 4 medication, I will take only 2, and maybe I will live more serene, not thinking. So, I mean, I don't believe that you can tell the doctor who is placing a stent in that 90% obtuse margin that is making an inappropriate procedure.
Do you do ischemic testing? I'm sorry to interrupt. Do you do ischemic testing to sort of justify? Do you do a stress MRI
if you have already ischemic testing in your hand before having done the angiogram, which is preferable, that's fine. But then is it acceptable to take the patient off the table, tell we're going to do ischemic testing, and then call you back, do another arterial puncture in 2 weeks, 3 weeks, and decide? I most probably I will go ahead and stent if the lesion is very critical, and if the marginal allows me to place a 3 millimeter stent. If I have to place a 225 stents, that's a different story.
I'll come to you a second, but let me just finish. So, Antonio, what percentage of your patients go to the cath lab already with some non-invasive imaging or ischemic evidence and then you go straight on to a cath query procedure? In stable population.
In stable, without clear-cut angina, not many.
But with some angina, you'll do some ischemic test first.
With some angina, some ischemic testing, but there are many patients with clear-cut angina who do not have ischemic testing. But without angina, I would say with minimal 30%.
Okay.
So it's not trivial.
Is that the same for you? Do you do cath query procedures in the US?
Yeah, so these are some great points, and I agree with both what Dr. Colombo and Dr. Burns said. I think the issue here, and this is probably not unlike the conversations we have now in the U.S., what we're trying to do is take these appropriate use guidelines. They're not regulations, they're not laws, and we're trying to shoehorn individual patient scenarios into them. So what Rob said, I think, is critically important. You have to take into account the specific patient population. You have to talk to the patient, discuss their preferences. We certainly have patients who say, I'm doing fine on 3 medications. I think I'm doing okay. And if I have worse symptoms, I'll come back. That's a valuable conversation. Yeah. There are some patients who say, look, I can't afford these 4 medications anymore.
But it's not quite like that. One, the affordability issue in Europe's not so much of an issue.
Sure.
And patients are knowledgeable now. They know about stenting. And they come to you and they say, I would like a stent. And you say, but you're okay on 3 medications. What are you going to do in that situation?
No, I think you're right, and I think that you have to. It ends up becoming a dialogue between you and the patient.
Yeah.
And trying to use guidelines for specific patient scenarios is challenging. I mean, all of us take care of patients. Human biology is not always what's written down in the guidelines. So it's good as a general approach. I can tell you that in the United States, the number of patients who are coming to the cath lab with non-invasive testing has skyrocketed. The use of FFR in the cath lab has gone up almost 500% because people want to make sure that not only are they doing the right thing, but they know that people are looking over their shoulder now.
Yeah. So what do you, just before we pass back to Antonio, I'm just going to ask you in a second about who regulates the so-called appropriate management of patients. Let's not call it appropriate stenting. What do you tell patients who've got who are doing cath query procedure, who've got a myocardial perfusion scan with some ischemic burden, perhaps 10%, 12% or something like that, and they come to the cath lab? What do you tell them about risk? How do you get informed consent?
So we try to do that beforehand, and I think that's something else that Rob mentioned. I think is important.
You don't know the angiographic
right, but I think it's important to have these conversations, and make sure patients understand what they're getting into before they hit the cath lab. In the specific patient scenario you're talking about, someone who is symptomatic, who has a mild area of ischemia, we do have a conversation with them about, balancing medical therapy versus PCI, what the risks of PCI mean, the fact that PCI may be associated with an increased risk of repeat procedures in the future. But the bulk of data tells us, COURAGE not specifically, but all the data beforehand tells us that PCI is slightly superior to medical therapy with respect to symptoms.
Okay, so let's go back. So Antonio and Rob in particular, if you wouldn't mind, we have a situation where we believe, and we could discuss and drill down to what is the appropriate management of patients with different levels of symptoms and what degree of ischemic testing they should have before they go to the cath lab and how you manage them thereafter. Are we sure that happens all the time in Europe? If not, how do we involve regulatory bodies, professional bodies? What's the place of audit? In Italy and in Germany, I can tell you about the UK, we looked very carefully at the BCS data and found 3% of patients didn't have non-invasive imaging and had CCS class 0.1. So we know roughly what our figures are. What do you think the situation is in Italy, and what should we do in Europe to ensure that good clinical practice in terms of percutaneous coronary intervention takes place?
It's very difficult to force physicians and to judge physicians, especially by other physicians. We know how opinionated are physicians, so I would be very scared to be evaluated by a physician. I believe a physician should improve his standard of care, because knowledge we disseminate tells that doing things in the right fashion makes patient feel better, make patient live longer, be protective of major events, and I believe that should be the major stimulus, should not be someone that comes and expects your charts and gives you a lawsuit. I mean, this is real life, but on the long term, appropriate education, appropriate awareness of what is good and bad should be the major stimulus for physicians doing things right.
Now, some people would disagree. Some people would say that self-regulation doesn't necessarily work, and there should be role of the professional body.
I don't mean self-regulation. I mean regulation by your peers that look at what you are doing. And if you are doing something inappropriate, your peers will, especially in a big institution, will be not easy to defend inappropriate procedures.
Yeah.
We have a very big policy of audit in the UK. People put in all their cases, and so we know we have various plots that allow us to see who are outliers. Is that a good thing, Rob?
Yeah, I mean...
Or would you go along Antonio's lines of education, meaning that people won't do unnecessary, so-called unnecessary stenting?
Yeah, I mean, I would agree, I think, with Antonio in that I think there's two pillars of, I think monitoring is a problem. I mean, everybody knows the guidelines, but adjudicating on whether people adhere to them, whether individual cases are appropriate is difficult, and most countries don't have formal monitoring procedures in place. I think internal audit in a large centre is certainly useful, and I think informal peer review is it probably plays a large part in identifying these cases.
Not national audit.
I think national audit also has a role, but not all countries have well-developed networks for national audit, like, for example, in the United Kingdom.
Okay,
you know, of course, I don't. I'm not. Don't misinterpret. There are some grossly inappropriate procedures, but that's beyond our discussion.
We are.
They're rare.
They're rare. So I think those grossly inappropriate should be pursued and should be strongly inspected. But we are assuming that we are above that level.
And we can assume that, can we?
I hope so.
So let's have a short comment from each of you before I sum up. So the comment is, was this a storm in a teacup? Is this going to go away? Has it helped reflect our practice? What's going to happen over the next few years, perhaps from the US perspective and then the European perspective from my two European colleagues, and then I'll sum up. Give us a little insightful comment as to...
So I think it's absolutely a storm in the United States. It was a long time coming. The United States healthcare system, as Dr. Colombo indicated, is substantially different from other areas of the world. I think that this ultimately is going to be a good thing. I think that external peer review is probably coming. And I think the appropriate use criteria, provided that they're used appropriately, are ultimately a good thing. I think it's going to make us all better.
Okay. It is. We could spend a whole time talking about who does the appropriate use criteria, because clearly there's data that shows when the panel thinks it's inappropriate, most of the physicians don't agree.
Exactly.
So that's a conversation for another time.
We'll be here all day.
Yeah. Rob, tell us, was this a useful exercise in European terms? Clearly in the United States it's different. But in Europe, has this helped us to reflect on our own practice?
I think it has a little. I mean, certainly the point is well made that this is an area that has received far less attention in Europe than it has in the United States. But if it causes us to reflect on our practice, I think that's certainly a good thing. I mean, we're all aware that PCI is an excellent treatment for patients with symptomatic stable angina. And I think in the future we're perhaps looking at ways where we can better modify our selection of these patients. We know, for example, we haven't mentioned the excellent FAME study, but if we look at selecting our patients more appropriately, we can reduce death in MI and still perform very effective PCI for our patients.
So there's still work to be done. Antonio, in Europe, are we okay? Do we need better reflection? What do you think is going to happen in the future? Do you do less stenting now as a result of Courage, for example? How's it all influenced your practice?
But even in a social medicine environment like in Europe, we are using resources, and the resources we use in stenting are necessarily taken away from other fields. So I think we have to be responsible. And we know that resources are not without limits. And I believe we have to make this decision to use less resources where there is no such a need in order to allow more resources to be used where there is more need. Do more stenting in acute coronary syndrome, in acute MI, and maybe more selective stenting in stable angina.
Yeah.
Maybe the number of stents will going to stay the same, maybe even increase. But that's using resources where there is more cost-benefit ratio.
Yeah.
So I think that's an extremely valuable point to bring this discussion to a close, and I think it's the comments of a very experienced physician who tells us that it is sort of about resources as well as patients. In the United States, it's clearly about whether or not stenting has been done for initiatives or not, and we don't know the answers to that until all the investigations have taken place. On this side of the channel, I think it's slightly different. We feel that there isn't that incentive, but we've come full circle, and I think for patients' sake and for all patients' sake, not just patients with stenting, but for all patients receiving cardiological care, for example, it is appropriate that we make sure there's no inappropriate stenting. And the inappropriate stenting may be where patients are well managed medically and don't have a significant lesion. And I think that I've learnt a lot today, and I've learnt quite a lot from the stormy United States to help me reflect on my practice. And so I thank all three of you for your incredibly insightful comments, and hope we can discuss it again. So thank you very much for joining us here at EuroPCR. I hope you enjoyed our discussions, and I hope it's been a stimulus to your own thoughts about your own practice. Thank you.